And with that, Dr. Su will now introduce our next speaker, Dr. Chao Ding.
Hi, it's a real pleasure to introduce a good friend and a friend of the Nebraska Oncology Society back to our event. Dr. Chao Ding is an attending physician on the breast cancer service at Memorial Sloan Kettering Cancer Center. Her clinical research focuses on developing more effective and less toxic treatments for women with this disease. Her particular interest is in evaluating combination therapies that include anti-HER2 drugs with chemotherapy in treatment of patients with early stage and metastatic HER2 positive breast cancer. Her research has changed standard of care practice. She has led investigator-initiated trials that have led to NCCN endorsement of dose-dense anthracycline taxane-containing chemotherapy regimen, followed by trastuzumab, dual anti-HER2 therapy with trastuzumab and pertuzumab with chemotherapy, and dual anti-HER2 therapy with trastuzumab and lapatinib with chemotherapy. So welcome, Dr. Dang.
Thank you so much, Dr. Shu. It's so nice to see you since COVID. My gosh, I've missed you guys, and thanks for having me back. So it's such a pleasure to be back, and I miss seeing all of you in person, but hopefully in the future. So today I'm going to discuss five key abstracts. Let me just change the presentation here. From ASCO this year. So it's going to be broken up into three groups. The first three abstracts are for patients with hormone receptor positive, HER2 negative breast cancer, and really going to highlight Destiny Breast 04, which was really the star at ASCO this year, presented by Dr. Modi and colleagues at the plenary, and discuss on Tropics 02 by Rugo et al., maintained by Kalinsky et al., and the HER2 positive safety updates on the Destiny Breast 03 trial, and also discuss on the triple negative study Keynote 522. So let's start out with the first group of patients here, the hormone receptor positive. So this is Destiny Breast 04. This is an incredible study that really received a lot of accolades for this particular drug in patients with HER2 low breast cancer. This is a new entity that comprises about 50% of our patients with breast cancer. And this is a trial that was reported by our friend and colleague, Dr. Shnu Modi, at the plenary. So let's talk about HER2 low. So HER2 was typically described in a binary way as HER2 negative or HER2 positive. HER2 positive for ASCO guidelines is IHC 3+ and FISH amplified with a ratio of at least 2, and HER2 negative is everything else, IHC 0, 1+, 2+, and ISH negative. So the HER2 low group is comprised of the IHC 1+, 2+, ISH negative. And HER2 low metastatic breast cancer has been treated as a HER2 negative breast cancer with therapies that target the hormone receptor status, as well as therapy that targets the triple negative population. And for patients with hormone receptor positive HER2 negative status, an endocrine therapy and CDK4/6 inhibition is our standard of care, and therapies after this has limited efficacy. And there's limited efficacy for patients who progress beyond multiple lines of chemotherapy. So trastuzumab deruxtecan. So this is TDXD, which is a monoclonal antibody. And the antibody is trastuzumab. The drug is a highly potent TOP1 inhibitor. And there's an 8-to-1 drug to antibody ratio with a cleavable linker. And this drug is already approved as second-line treatment for patients with HER2 positive metastatic breast cancer. And the drug binds to the HER2 receptor, it's internalized, the linker is cleaved, releasing the TOP1 inhibitor. It enters the nucleus, and because of the membrane permeable capability of this drug, it is released and it has a bystander effect. So results from a phase 1b study have reported the efficacy of TDXD in heavily pretreated patients who are HER2 low, with a median PFS of over 11 months and a response rate of 37%. So this is the Destiny Breast 04 trial. This is the first randomized phase 3 study of TDXD for HER2 low metastatic breast cancer. In this study, patients were enrolled if they had HER2 IHC 1+ or 2+ ISH negative with unresectable and or metastatic breast cancer treated with 1 to 2 prior lines of chemotherapy. And patients have hormone receptor positive disease and they must be considered endocrine refractory. Patients were randomized 2-to-1 to T-DXd at standard dosing or treatment physician's choice, TPC, and they included capecitabine, eribulin, gemcitabine, paclitaxel, or nab-paclitaxel. The primary endpoint was progression-free survival by blinded independent central review. And the key secondary endpoints included PFS in all patients and OS in hormone receptor positive and all patients. Now, in terms of patient characteristics as seen here, the median age was 56. In terms of IHC status, about 58% had IHC 1+ and 42 IHC 2+-ish negative. This is predominantly a hormone receptor positive population in 90% of the patients, and 10% had hormone receptor negative, otherwise known as triple negative breast cancer. In terms of burden disease, over 60% of patients had liver metastases at baseline, and a third of patients had lung metastasis. Now, in terms of number of lines of therapy, the median lines of therapy were 3 for metastatic breast cancer. In terms of lines of chemotherapy, it was 1. In terms of lines of endocrine therapy for patients with hormone receptor positive breast cancer, it was 2. And in terms of the usage of CDK4/6 inhibitors, it was about 70% of patients. Now, here are the results. To the left, in terms of PFS for patients with hormone receptor positive breast cancer, you see here an improvement in progression-free survival from 5.4 months with TPC to 10.1 months with T-DXd, with hazard ratio of 0.51, a p-value of less than 0.0001. To the right, you see nearly identical curve for all patients, meaning 90% of patients being hormone receptor positive and 10% being triple negative, that the median PFS was from 5.1 months with TPC to 9.9 months with T-DXd, a hazard ratio of 0.5, a p-value of less than 0.0001. These data are astonishing. Now, moving on to overall survival in patients with hormone receptor positive breast cancer, to the left, as you see here, there was a significant improvement in OS from 17.5 months in TPC to 23.9 months with T-DXd, with a delta of 6.4 months, a hazard ratio of 0.64, a p-value of 0.0028. And to the right, in all patients, meaning HR positive and triple negative, you see here the curves are nearly identical. Now, in exploratory analysis in patients with triple negative breast cancer, meaning hormone receptor negative, HER2 negative, you see here to the left, the PFS was 5.6 to 8.5 months. Remember, the triple negative subset of patients numerically have numerically lower PFS in general. So these data are certainly consistent with what we know about the biology of this disease. And to the right, in terms of OS, you see here an improvement in OS from 8.3 months to 18.2 months with a delta of 9.9 months. Now, when looking at subgroup analysis, you see here that the gain in PFS was seen across all subsets in favor of T-DXd, regardless of IHC status, prior lines of chemotherapy, age, race, region, or whether they had visceral disease at baseline or not. Now, in terms of drug-related treatment emergent adverse events, there were no surprises. For patients who received T-DXd, there were more patients who had nausea, but most of it was grade 1 and 2. And for patients who received TPC chemotherapy, more patients had neutropenia. Now, in terms of overall safety summary, now remember the median treatment duration of patients on T-DXd was 8.2 months and TPC was 3.5 months. And the most common treatment emergent AE associated with treatment discontinuation for T-DXd was ILD pneumonitis in 8.2%, and for TPC, it was peripheral sensory neuropathy in 2.3%. In terms of the most common treatment emergent AE associated with dose reduction for T-DXd, It was nausea and fatigue in 4.6% of patients and neutropenia in 14% of patients receiving standard chemotherapy. In terms of total deaths, it was 3.8% in TXD and 4.7% in TPC. And I note here that there were 3 deaths related to ILD in patients receiving TDXD. Now, this drug received a lot of interest many years ago, but certainly we learned about the rates of ILD pneumonitis. And with further trials and monitoring, the rates have been lowered, as we see here in this trial that any grade ILD for TDXD was about 12%. However, there were 3 deaths here related to ILD. In TPC, the rate of ILD pneumonitis was only 0.6%. It was 1 patient with grade 1. In terms of left ventricular systolic dysfunction, for all grade LVSD, it was 4% for TDXD, with 1 patient with grade 3 LVSD and heart failure. So in conclusion, the DESTINY-Breast04 established TDXD as a new standard of care for patients with HER2-low, hormone receptor positive, HER2-negative metastatic breast cancer. It is the first HER2 targeted therapy that has demonstrated unprecedented statistically significant improvement in progression-free survival and overall survival. And there was similar magnitude of benefit across all subgroups, including IHC status and prior CDK4/6 inhibitor use. The safety of this drug was consistent across known safety profile in prior studies. And DESTINY-Breast04 has established TXD as a new treatment option for patients with a new targetable population called HER2-low. So this is a very exciting trial for a drug, for our patients with this drug. Now, we look forward to the approval of this drug, and I'd like to go ahead and now transition to a second drug that has garnered some interest as well. This is another antibody drug conjugate called sacituzumab govitecan, excuse me. This is the primary results from the TROPiCS-02, which is a randomized phase 3 study of SASI versus treatment physician's choice in patients with hormone receptor positive, HER2-negative advanced breast cancer. So SASI is the first-in-class TROP2 directed antibody drug conjugate. TROP2 is a membrane signal transducer linked to poor prognosis and is highly expressed in 80% of breast cancer, regardless of subtype. And SASI is already approved for patients with metastatic triple-negative breast cancer who received at least 2 prior lines of therapy. Now, in a phase 1/2 study, SASI also showed encouraging activity in patients with hormone receptor positive HER2-negative breast cancer that showed response rate of 31% and a median PFS by investigator assessment of 5.5 months. So that has led to the conduct of this trial, TROPiCS-02, which is a phase 3 study of SASI in patients with hormone receptor positive, HER2-negative, locally recurrent, inoperable, or metastatic breast cancer. And patients were enrolled where they had to have at least 1 endocrine therapy, a taxane, and a CDK4/6 inhibitor in any setting. But they could have at least 2, but no more than 4 lines of prior chemotherapy. And patients were randomized 1-to-1 to SASI, given here days 1 and 8, every 21 days, versus treatment physician's choice. And the treatment physician's choice chemotherapy agents were capecitabine, vinorelbine, gemcitabine, or eribulin. As you see here, over 500 patients were enrolled, and the primary endpoint was progression-free survival by blinded independent center review. And secondary endpoints included OS, response rate, clinical benefit rate, duration response, and PRO and safety. And here are the demographics. To the left, in terms of the median age, it was 55 to 57. Now, in terms of patients with visceral disease, the majority of patients had visceral metastases of about 95%. And the majority of patients also had liver metastases of about 84 to 87%. And over a quarter of patients had de novo metastatic breast cancer. To the right, in terms of the percentage of patients that had prior chemotherapy or treatment in the early breast cancer setting, it was about 65%. In terms of patients who had prior endocrine therapy in the metastatic setting, it was about 86%. In terms of the usage of CDK4/6 inhibitor, which is standard, about 60% of patients had CDK4/6 inhibitor exposure of 12 months or less, and about 40% had it for greater than 12 months. Now, here's the primary endpoint for PFS by blinded independent central review. In the ITT population, as you see here, sacituzumab led to median PFS of 5.5 months versus 4 months with TPC. The hazard ratio was 0.66, p-value 0.0003. In terms of 6-month PFS rate, 9-month PFS rate, 12-month PS rate, sacituzumab was better than TPC. The 12-month PFS rate was 21 versus 7. Now, although this seems like a small delta of only 1.5 months, remember, this is a heavily pre-treated population where the median PFS is about 3 to 4 months. In terms of PFS subgroup analysis, as you note here, that there was a benefit of SASI in most subgroups, in all subgroups, quite frankly, as predefined here, including patients with at least 3 prior chemotherapy in the metastatic setting, patients with visceral metastases, and also older patients. Now, in terms of the overall survival benefit in the ITT population, this is the first planned interim analysis. And so far, we don't see a statistical significance yet, but these data are immature, but it's interesting to see the curves separating. So we await for more time. Now let's look at the key all-grade treatment-related adverse events. Now, not surprisingly, to the left SASI, there were more patients with grade 3 neutropenia, 9% with grade 3 diarrhea, and more patients with fatigue, about 6%. But there were no events of interstitial lung disease in the SASI arm versus 1% in TPC. Now, in terms of the EORTC quality of life assessment, that we see here that there was delay in diminution of quality of life in the SASI arm to the left and fatigue to the right. So in terms of conclusion of the study, that in a heavily pre-treated population with hormone receptor positive, HER2 negative advanced breast cancer, in patients who have received prior endocrine therapy with CDK4/6 inhibitor with at least 2 prior chemotherapies and no more than 4, that SASI was better than TPC in terms of improvement in progression-free survival with the delta, albeit small, of about 1.5 months, but it was considered statistically significant. And in terms of the overall survival analysis, I think we need to wait for longer follow-up to look for the result. And there was an overall quality of life benefit over TPC with SASI. And the safety of SASI was manageable and consistent with previous studies. So overall, in a heavily treated population, certainly SASI may have an indication in this space, but we wait to see what the regulatory approval agencies will say about this result. Now, moving on to the third trial that I think is interesting to discuss, which is the MAINTAIN trial, really looking at the efficacy of CDK4/6 inhibitor beyond CDK4/6 inhibition previously in patients who progressed on a prior CDK4/6 inhibitor with endocrine therapy. So this is a randomized phase 2 study of fulvestrant or exemestane with or without ribociclib after progression on an anti-estrogen plus CDK4/6 inhibitor in patients with metastatic hormone receptor positive HER2 negative breast cancer. This is the MAINTAIN trial. So CDK4/6 inhibition with endocrine therapy is the standard of care for patients with hormone receptor positive HER2 negative metastatic breast cancer. There have been several phase 3 trials that have shown the efficacy with 3 CDK4/6 inhibitors, both in the front line and in the second line setting. Now, ribociclib with endocrine therapy improves progression-free survival and overall survival in both the first and second line setting. It is the only CDK4/6 inhibitor that has shown OS benefit in both lines of treatment. Now, anti-proliferative effect of CDK4/6 inhibition can reverse upon discontinuation. And there have been observational data that have shown some benefit of treating with CDK4/6 inhibitor and switching endocrine therapy after CDK4/6 inhibitor progression. In other words, in patients who have CDK4/6 inhibitor with endocrine therapy who progress and who switch to endocrine therapy, another endocrine therapy, and continuation with a CDK4/6 inhibitor, that there may be some benefit. However, there have been no prospective trials that have reported this approach. And this is the trial that is to report that. This is the Maintain trial. In this trial, patients were enrolled if they had hormone receptor positive breast cancer with ER or PR of at least 1%. They had to have progression on endocrine therapy plus any CDK4/6 inhibitor. They could only have up to one line of chemotherapy for metastatic breast cancer, and they had to have measurable or non-measurable disease. Stable brain mets were allowed. And in this study, patients were randomized 1-to-1 to switching endocrine therapy with ribociclib at standard dosing or switching endocrine therapy with placebo. There were 120 patients enrolled. The endocrine therapy that was allowed was fulvestrant or exemestane. Fulvestrant was the endocrine therapy given if patients had progression on a prior aromatase inhibitor for metastatic breast cancer and who have had no prior fulvestrant. Exemestane is allowed if patients have had progression on prior fulvestrant. The primary endpoint of the study was progression-free survival as assessed locally. The secondary endpoints included overall response rate, clinical benefit rate, safety, tumor and blood markers, including circulating tumor DNA. Here are the patient characteristics. As you see here to the left, that the median age was about 55 to 59. In terms of de novo metastatic disease, more patients in the placebo arm had de novo metastatic disease of 54% versus 35%. In terms of visceral metastases, about 60% of patients had visceral metastasis. And in terms of chemotherapy for metastatic breast cancer, more patients in the placebo arm had chemotherapy for metastatic disease of 12% versus 7%. To the right, in terms of CDK4/6 exposure, there are 3 CDK4/6 inhibitors. That's palbociclib, ribociclib, and abemaciclib. In the study, the majority of patients were treated with palbociclib in the order of 86 to 87%. This is likely because palbociclib was the first approved CDK4/6 inhibitor. In terms of the median duration of prior CDK4/6 inhibitor in terms of months, it varied between 15.5 to 17 months. Now here's the primary endpoint. In terms of a progression-free survival, Maintain shows that by switching endocrine therapy and maintaining on a different CDK4/6 inhibitor, namely ribociclib, you see here there was an improvement in PFS from 2.76 months to 5.2 months. The p-value was 0.006, hazard ratio is 0.57. And this is certainly very interesting to see data that by continuing a CDK4/6 inhibitor, we could see improvement in outcomes over stopping CDK4/6 inhibitor. But note, in the study, it was a different CDK4/6 inhibitor given in patients who've had prior exposure, mostly to palbociclib, and a small group of patients had ribociclib exposure. In terms of progression-free survival at 6 and 12 months, as you see here, there was an improvement in 6-month progression-free survival in favor of the ribociclib arm, that is from 23.9% to 41.2%. And there was an improvement in progression-free survival rates at 12 months from the placebo arm of 7.4% to 24.6%. Now, in exploratory analysis, in looking at if there are differences in PFS, depending on the endocrine backbone, there does not appear to be a difference to the left in terms of patients receiving fulvestrant with CDK4/6 inhibitor ribociclib versus placebo. You see here that there's a split in the curves, as noted here, with a median PFS of 2.76 months versus 5.29 months, hazard ratio of 0.6. To the right is in the group of patients who received exemestane as their endocrine backbone. And again, there's a split in the curves in favor of patients receiving ribociclib versus placebo, with a median PFS from 3 months versus 5.36 months. And looking at progression-free survival by the subgroup, we highlight here that note here again, the majority of patients had prior palbociclib and progressed. And as noted here, there was a benefit in this group. But interestingly, there was a small group of patients who had ribociclib and who progressed and who went on to continue ribociclib, but switching the endocrine treatment that you see here that that the line crosses one, but this is such a small group, so it's hard to conclude here. So for treatment-related adverse events, no surprises here. Ribociclib to the right in blue, placebo in left, that there were more patients who had all grade neutropenia of 72% versus 15% in placebo, but most notably, 38% of them had grade 3 neutropenia. And in this group, about 3% of patients with ribociclib had febrile neutropenia and 0% had febrile neutropenia with placebo. And you see here that in the ribociclib group that the all-grade thrombocytopenia was 25% versus 5% in placebo. And in terms of pneumonitis, lung toxicity, that it's worth noting that these drugs do cause pneumonitis, and it's a small percentage, but something to look out for, that in the ribociclib group, essentially the all-grade pneumonitis rate was 3%, with about 2% being grade 3, as noted here. So in conclusion, so this is the first randomized trial to show a benefit of ribociclib in switching endocrine therapy after CDK4/6 inhibitor progression, where the majority of the patient had received prior palbociclib. There was a significant improvement in PFS compared to placebo, and there were higher rates of PFS at 6 months and 12 months. So I think this is certainly very, very intriguing and encouraging data. It deserves validation to see if these data hold up, and certainly deserves a comparison against other therapies that will likely be approved soon in the space for patients with hormone receptor positive HER2 negative breast cancer. So takeaway for patients with hormone receptor positive breast cancer, the first trial, DESTINY-Breast04, there's a new targetable group, that is the HER2 low group, which is HER2 IC1 plus or 2 plus-ish negative, that we've seen that T-DXd has shown an improvement in PFS and OS over TPC in a group of patients with unresectable or metastatic breast cancer with 1 to 2 prior lines of chemotherapy. And T-DXd should become the new standard care option in the HER2 low group in this setting. So we anxiously wait for its approval. The second study is the TROPiCS-02, which is sacituzumab, that has shown an improvement in PFS over TPC in patients with at least one endocrine therapy who've had prior taxane, who've had prior CDK4/6 inhibitor, and who've had no more than 4 lines of prior chemotherapy. And this may become a potential treatment option for this heavily pretreated population. And thirdly, maintain a very provocative trial. It's a small phase 2 trial, but certainly shows that by continuing a CDK4/6 inhibitor, in this case, ribociclib, and switching endocrine therapy, that we saw a significant gain in PFS over switching endocrine therapy alone after progression on prior CDK4/6 inhibitor. These data are encouraging and needs validation. Now, moving on, in the last 2 abstracts, I'd like to discuss one abstract, which is for the HER2 positive population. Again, T-DXd made the stage again. This is DESTINY-Breast03, and this trial needs very little review because it's been highlighted several times. So Destiny Breast 03 essentially compared T-DXd against TDM1 in patients with HER2 positive metastatic breast cancer in the second line beyond space. And as we see here to the left, that there was a significant improvement in progression-free survival, T-DXd over TDM, with a median PFS that has not been reached yet, but for TDM it's 6.8 months with a hazard ratio that's 0.28 and p-value 7.8 times 10 to the minus 22. So we've never seen data like this. And this is certainly astonishing. And T-DXd has become the preferred second line treatment option for patients with HER2 positive metastatic breast cancer. Now, the purpose of this reporting at ASCO this year was to provide an updated safety data with additional analysis with patients being treated in Destiny Breast 03, with further follow-up with safety data cutoff at September 7th, 2021. So here we see the safety update with a data cutoff of September 2021. In terms of T-DXd and TDM, the overall any grade treatment emergent adverse event rates were similar in both, about 95 to 99%. In terms of grade 3 treatment emergent adverse events were about 49.8 to 53% for T-DXd. But in terms of treatment adverse events leading to drug discontinuation, it was doubling in T-DXd at 14% versus 7%. In terms of treatment emergent adverse event associated with dose reduction, again, it would almost nearly double with T-DXd at 23% versus 14% for TDM1. Now, let's look at the exposure adjusted incidence rates. Now, exposure adjusted incidence rates were measured to account for the differences in treatment duration exposure between T-DXd and TDM1 to provide a more meaningful comparison, meaning T-DXd patients were exposed to the drug a longer period of time here, of a mean of about 16 months versus 6.9 months with TDM. And the exposure adjusted incidence rates per patient year were lower for T-DXd arm than the TDM arm, except for the adverse events associated with drug discontinuation, which were mainly due to ILD pneumonitis in the T-DXd arm. The adjusted incidence rates for grade 3 or higher TEAEs was 0.42 for T-DXd and 0.7 for TDM. And for any grade serious TEAE was 0.17 for T-DXd and 0.27 for TDM. Now, moving on to drug-related toxicities, TEAEs reporting at least 20% of patients. Again, no surprises for T-DXd on the left in blue, that there were more patients who experienced grade 3 nausea, fatigue, vomiting, neutropenia, and a third of patients had all grade alopecia, mostly grade 2, and more patients had anemia, leukopenia, and decreased appetite who received T-DXd. And again, no surprise for TDM1 to the right, that more patients, about 25%, experienced grade 3 thrombocytopenia. Now, in terms of time to first occurrence for nausea and vomiting, these events occurred early for both, but as you note here in the dark blue, that patients with T-DXd, more patients experienced nausea, and that was persistent throughout, and more patients experienced vomiting. So today, when patients are getting T-DXd, they're given appropriate antiemetics to mitigate these toxicities. In terms of time to occurrence for fatigue, to the left, as you see here, the rate's about the same for both T-DXd and TDM, and fatigue was persistent throughout treatment. For alopecia, to the right, the more patients experienced alopecia with T-DXd. And importantly, drug-related ILD pneumonitis, a toxicity that is of great interest when this drug is being given, that the majority of adjudicated ILD pneumonitis cases were low, and there were no grade 4 or 5 events. And with further follow-up, there was one additional grade 2 ILD pneumonitis, but the majority of events resolved with ongoing follow-up. So this is very encouraging to see that in this extremely effective drug, that there were no significant events in further follow-up and no deaths. So the bottom line from this safety follow-up on patients receiving T-DXd versus TDM in Destiny Breast 03 for patients with HER2 positive metastatic breast cancer, there were really no concerning safety signals with further follow-up with this trial. And certainly this data reinforces the favorable benefit risk profile of T-DXd over TDM for our patients with HER2 positive metastatic breast cancer. And really the takeaway from this study was that there's no new safety signal. This is an excellent drug. It is a preferred second-line option in patients being treated for HER2 positive metastatic breast cancer. Alrighty, so finally, last abstract, triple negative breast cancer. Alrighty, I would like to now discuss the last abstract, which was presented by Dr. Pustai and colleagues on a keynote 522, which is to present the event-free survival by residual cancer burden after neoadjuvant pembrolizumab plus chemotherapy versus placebo plus chemotherapy for patients with early stage triple negative breast cancer. This is an exploratory analysis from keynote 522. So keynote 522 data have already been reported. It is the first prospective randomized placebo-controlled phase 3 trial that assessed the efficacy of pembrolizumab in early stage 2-3 triple negative breast cancer in the neoadjuvant and adjuvant setting. And the primary analysis has already shown that neoadjuvant pembro with standard chemotherapy that included taxane and anthracycline resulted in a statistically significant and clinically meaningful increase in PCR. And that neoadjuvant pembro plus chemo followed by adjuvant pembro resulted in a statistically significant and meaningful improvement in event-free survival. So these data have led the FDA and EMA to approve pembro in combination with chemotherapy as neoadjuvant treatment and then continued as adjuvant therapy in high-risk early-stage triple-negative breast cancer. So the objective of this reporting is to evaluate the event-free survival by treatment arm with residual cancer burden by categories 0, 1, 2, 3. So RCB0 is essentially PCR, pathologic complete response. And RCB 1 and 2 and 3 essentially correlates with increasingly larger residual cancer burden. This was a pre-specified exploratory analysis, and here we report the data. Before we do that, let's review the study. Here it is again, keynote 522. Patients were enrolled if they had stage 2-3 triple negative breast cancer, meaning that they could have T1C, N1, N2 disease, or T2 to T4, N0 to N2 disease. And tissues were collected for PDL testing. Patients were randomized 2-to-1 to chemotherapy, carboplatin paclitaxel, followed by anthracycline cyclophosphamide with pembrolizumab given every 3 weeks during treatment, or chemotherapy with placebo. And patients went on to surgery and they continue on their assigned treatment. The patients on the pembro arm continue pembro, the patients on the placebo arm continue placebo for upwards of 9 cycles. And the median age was 49. This was a young patient population. Over 80% of patients had PDL positive disease, less than 20% had PDL negative breast cancer. 57% of patients received carboplatin in a weekly schedule, 40% in a Q3-week schedule. About three-quarters of the patients had T1, T2 disease, and about half the patients had lymph node positive disease, half had lymph node negative disease. Here's the primary analysis. We go over it again on the left side in terms of the PCR gain, as you see here on the left, that the addition of pembro to chemo led to an improvement in PCR from 51.2% to 64.8%, a delta of 13.6. And there was no notable in patients whether they had PDL positive disease or not. And to the right, the event-free survival was reported later. Here you see that there was an improvement in event-free survival at 3 years from 76.8% to 84.5%. So pembrolizumab was approved in combination with standard chemotherapy as neoadjuvant therapy with chemotherapy, followed by adjuvant pembro in patients with clinical stage 2-3 triple negative breast cancer, regardless of whether they have PCR or not. Now, let's look at the prevalence of RCB in this population. This was an exploratory analysis. As you see here to the left, that the patients who received pembro in green had RCB0 of 63% versus 56%. So more patients had RCB0 if they received pembro. Now to the right, in terms of RCB1, RCB2, RCB3, that the patients who received pembro in the green, essentially less patients who received pembro had RCB1, 2, and 3. So essentially it appears that pembro exposure essentially shifted the RCB category to lower category for patients who've been treated with pembrolizumab. Now, in looking at event-free survival for patients who had RCB0, you see here that patients did well regardless of the assigned treatment. You see here the event-free survival was about 92.6% in the no pembro arm versus 94.7% in the pembro arm. The event-free survival events were lower in patients who had pembro. In patients who had event-free survival based on RCB1, you see here that they did similarly well at 83.8% versus 84.4%. And numerically to the right, you see here in green, the patients who had pembro exposure had less EFS events at 17% versus 20%. What's striking is this one, where we look at the event-free survival in patients who had RCB2, meaning a higher residual cancer burden. And as you see here, the split in the curve, that the 3-year event-free survival was 55.9% in the no pembro arm versus 75.7% in the pembro arm, with lower event-free survival events in the pembro exposed group. And lastly, in terms of event-free survival for patients with RCB3, which was a very small group, you see the opposite effect, meaning patients in the pembro arm had lower event-free survival, but I caution this interpretation because there were very few patients for this analysis. Now, in terms of the summary of first event-free survival events, what's highlighted here is that the majority of the events were distant recurrence. The patients who received pembro had less distant recurrence compared to those who did not. In looking at the patients who had RCB0 who had pembro, the distant recurrence was about 3% for pembro versus 5.5% for placebo, and all the way to the right for patients with RCB3. For patients who had pembro exposure, it was 35% versus 54%. So the summary conclusion from this trial is that in a pre-specified analysis for event-free survival by RCB category, they showed that patients with higher RCB scores had worse event-free survival, independent of treatment group. That patients who had pembro had higher rates of RCB0 and basically lower rates of the RCB1, 2, and 3. So pembro exposure certainly shifted the higher RCB category to being lower. And the addition pembro resulted in fewer events in those with residual disease, most notably in those with RCB2 disease. So certainly taken together, these results certainly indicate that event-free survival benefit from pembro extends to those who essentially have residual disease. However, there are still questions about this trial, and I highlight here, it is still unclear how much benefit pembro offers in the adjuvant setting for those who achieve PCR today, who have RCB0. Now, by trial design, patients receive pembro in the adjuvant setting, regardless of whether they have PCR or not. So it is still unclear on the benefit of pembro in this population. But until we have data, patients with PCRs are to have pembro in the adjuvant setting. And certainly, what about the patients with residual disease, with high burden disease? For example, those with RCB2 or possibly 3, do these patients deserve more therapy in addition to pembro in the adjuvant setting? And this awaits more data to help us identify this high-risk population that may need more therapy beyond adjuvant pembro. So for now, Keynote 522 regimen is our standard option and is indicated for patients with clinical stage 2-3 triple negative breast cancer, where they will receive pembro and standard chemotherapy in the neoadjuvant setting, where about 64% of them will have PCR. but regardless of PCR or not, out back, they should be getting adjuvant pembro to complete until we have further data on whether we can avoid further pembro for those with PCR, and we need more work to identify who needs more therapy in addition of to pembro who have non-PCR. Thank you. All righty, we have about 6 minutes.
Wonderful. Chow, thank you so much for a wonderful talk. We'll take questions.
I just want to remind anyone who has a question to please either unmute yourselves or type those in the chat box.
Okay, looks like there's no questions. So thank you so much again, Dr. Dang, and hopefully we'll see each other soon.
Thank you. Have a great conference the rest of the day. Thank you.
Thank you.